So I'm very happy to be here and see such beautiful faces on a lovely Saturday morning. So we're here to talk about scleroderma and the many aspects of pain. And this will have a lot to do with recognition, both our recognition, but so that we can help our clinician, physician, or whoever we're working with, help them understand and recognize what's going on for us so that they could better diagnose the issue. Because in scleroderma, there's many reasons for pain. And following the thread, looking at patterns, is going to help us figure it out and then gravitate towards a treatment that's going to be efficacious. Okay, disclosures. Human, yeah. I'm human's best friend. Okay, so we're going to talk a little bit about quality of life and symptoms drive quality of life in health conditions. Symptoms, we're not stuck with them. They are modifiable. We can work with them. If we can't resolve them, we can at least work with them and manage. And there's a number of reasons why somebody living with systemic sclerosis will have symptoms. It could be from the disease itself. It could be indirectly from something maybe related to medications or related to any other event. So what are symptoms? We'll talk a little bit about that. Multifactorial. Multifactorial is a fancy word to say multiple things. So many things converging, several things converging, and that's often the case in systemic sclerosis, is that this is a multi-organ system disease that affects multiple parts of our bodies in different ways. And there's different mechanisms that create issues. So there's going to be, for people living with systemic sclerosis, maybe 2, 3, or 4 reasons that you feel fatigued. It could be the inflammation, for example. It could be the inflammation's effect on the brain. It could be because you're in pain. That causes fatigue. It could be because you're not sleeping so well because of whatever reason. So all of those things contribute to fatigue as an example. So that's multifactorial, multiple causes. And so it's important for us to get good at teasing apart these patterns in our life so we can zero in on, if we're lucky enough, there's one cause, but if there's more than one cause, that we can isolate them and then try to tackle each one of those so that we can move towards what we feel is our baseline or what we can cope with. Okay. So we're going to be working on focusing on developing those skills, and we're going to also talk about reasons for pain and systemic sclerosis. We're going to go organ by organ, and we may not have enough time to get through everything, but there are handouts, and we can. I'll be available to speak. I'll be in Salon 6 next, so you can follow me there if you have any further questions. But one of the things that I really want to stress is that things don't change overnight. This is an incremental process, a process of becoming more familiar and kinder to oneself in order to be able to be sensitive enough to recognize the things that we're feeling and those patterns that are created, and then how to communicate them. And we have to be forgiving to ourselves. Okay, so in your resources, there are 2 articles that we wrote based on quality of life. This first one based on quality of life and taking the approach of care by addressing first and foremost following of life, and then we can quality of life, and then we can follow that thread back to the cause. We try to write our articles in a way so that patients can read them, understand them, because oftentimes it's going to be patients that need to be delivering information to their clinician who are not scleroderma specialists. And we all need help because this is a very complex disease. And then this is the other article, and this is an overall approach to care. in systemic sclerosis, acknowledging that it's a multi-organ system disease, and how to screen, how to diagnose, the elements of counseling. So it's a really detailed article, but it's meant to be a reference. You can't sit in 1, 2, 3 sittings and get it all. So it's there for you to go back and look things up. So don't feel oppressed by thinking that you have to read it. So quality of life is super important. And it's probably the single most thing that patients can latch onto as being a priority for them. Because when our quality of life is impacted, it impacts everything else. So when we have symptoms, whether they're physical symptoms or emotional or psychological symptoms, they can interfere with our ability to move through the world with ease. And so it's addressing these quality of life issues that can be super important in helping people feel the best that they could be. And so quality of life includes family, social engagement, work issues, issues related to intimacy, employment, and also the difficulties that we might feel financially because of having a chronic health condition. So these are important things, as important to life-saving medication, because our best life is lived in a place of ease. So where are these symptoms coming from? Symptoms, again, they can be physical, of which there are a number in any one person. We're all different with systemic sclerosis. Everybody presents differently. Everybody has different experiences. So physical symptoms are a spectrum. Psychological, there's a lot of psychological burden. There's situational depression, there's anxiety, not knowing about the future. These are things that can really impact how we feel about our life and how we move through it. And cognitive, so physical symptoms and depression and fatigue that could be related to inflammation, these things also kind of take a toll on our ability to think and to calculate. But remember, all of these are modifiable. Let's move forward. So basically, quality of life is improved or impaired by augmenting certain things in our resources or diminishing them. So things like clinician communication. Is there a way of making the screen bigger? Because I'm having trouble seeing my slides. Sorry. So if we can reduce symptom burden, we know that we can increase quality of life. If we have good clinician communication, already we're feeling better. So all of these things, various influences, augment or eat away at our quality of life. And we know that when we address symptoms and we try to improve our experience of these symptoms, we not only improve our quality of life, but this is also tied to better survival and adherence to medication and overall health outcomes. So we want to be proactive in problem solving and using our interactions. Communication strategies are super important. Understanding the clinician when they're talking to us is very important. Being able to stop and say, I don't understand. And taking the time to understand the symptoms. So we're going to go into that. So clinician-patient interactions, what are they made of? They're made of, first of all, identifying the problem. And then moving forth with investigation, whether that's questions, examination, or further testing. And then management, short-term, long-term management should be addressed, and follow-up. Um, what are you going to be doing at home? What changes over time will you be making to try to ameliorate that? Where are you being referred to anybody? Are you being provided additional medications? So this is the basic structure of what happens um, when we see our clinician. And then, of course, very importantly, there will be a follow-up visit where these things will be these items will be reassessed. So this is how we feel when we're overwhelmed by our symptoms. We feel overwhelmed by them, and then because we feel so overwhelmed, sometimes it can be difficult to express ourselves. And then when we get into that frame, then it's difficult to hear information too. Um, and so, and when we get, and then that makes it difficult to think, and to have a conversation. It's like a deer in the headlights, because we feel so urgent about the symptoms. So, one important strategy is to think about calming the overwhelming sensation and being able to see the wood for the trees, naming, listing, describing before we get to an appointment is really important. That we've taken the time, and non-urgent time, because when we get in front of a clinician and we think this is my chance, this is to get this done, to get this taken care of, to get this wiped out of my life. But actually, we have to be thinking about these things in a non-urgent space, in a space where we have time to think, we have time to review our experiences, to write, to list, to describe for ourselves, find the adjectives that are going to help that clinician zero in on those one or several things that can be modified to improve our life. And that's psychologically meaning that this whole symptom experience has a manageable side to it psychologically. And then the I want to say monster, but it's kind of this overshadowing thing in our life, then it has a little less control over us when we can describe it and we can communicate about it, and when we can get help. So calming the overwhelm, what to do, naming the sensations and concerns, slowing down the mind is really important, trying to get out of that urgent space so that we could get into our thinking space. Mindful activities, walking, sitting, outdoors, anything that can settle the mind so that we can access that communicative, examining part of ourselves. Support groups is a great place to talk about these things and try to explore how to talk about what we're experiencing and hear other people's experiences, because we can find ways of talking about that same symptom, and we talk it out and we write it out. I really like this book, Time to Think, because it talks about how slowing down, we can get the answers. And it's a very good book if you're a support group leader, because what this book is about, it's about giving space for folks to talk, so that and having faith that through giving them the space to talk, they're going to be able to come to an empowering resolution. But this means somebody is having their space held for them while they have the spaciousness to think, offering the spaciousness to think. So I really like this book. And there's a great article in The Guardian. So clear communication, we want to be heard, right? We go to the doctor's office, we want to be heard. So what do we need to do? We have to plan ahead. However many problems we have for each of these, We have to state the problem, and we have to state the intensity of the problem, the intensity of interference, how it's interfering with our life. And then we have to be able to articulate, especially in pain, location, quality, the timing. We're going to have to talk more about this, and some alleviating measures that you might have experimented with. And then the last component of being heard is being engaged, is coming in, and we know our medications. We're able to address any previous plan that we've taken seriously, because hopefully we're all seeing clinicians whereby we're equal partners, and at the end of the visit, we're not being told what to do. We're there as decision-making partners. So we're able to update our clinician on our shared plan and what happened in the time in between. So being engaged, these are the four important elements related to really being heard as somebody with a health condition who's seeking help. But we always have unconscious influences in the way, because we always have baggage, right? And we can always let things interfere. Hell, this happens to me several times a day, every day, if not all day long, that I have to kind of redirect, no, that's not what's being said, right? Or how can I just get myself heard and calm down the situation? So there's sometimes we come to things with misplaced anger or frustration because we have a significant symptom, pain. And pain makes everybody agitated. It's hard to relate. It's hard to move. We may have misplaced anger from past healthcare experiences we've had that didn't go so well. We may be unloading frustration because of our health condition, our frustration with ourselves, that maybe we've internalized that we're not doing enough for ourselves, and that is coming out in all sorts of ways, whether it's over our health organization or our ability to communicate. And then sometimes depression can get in the way of communication, or overly coloring our communication. So it could impede us from communicating. It can impede us from being proactive. And it can impede our engagement and motivation. Depression can. So it's important to know, when we're noticing that tiger in us getting annoyed, or you feel like you just want to stomp out the door, because we all do. Everybody does. And so you shouldn't feel bad about that. But when it happens, it's good to just notice it's happening, and then redirect what's not helpful. Because by the end of a healthcare visit, you want to be able to have moved forward a bit, and so these are elements that color a visit, and discussing pain are fraught with these elements that can impede something positive getting done. So we want to be heard, we want a solution, and so we go to our nurse practitioner, our clinician. And so it's also important when we walk into a treatment room with a clinician to understand that that they don't have all the answers, that they're relying on us to provide these answers. And so we have to also recognize who we're walking into the room with. Where could they have possibly come from just before seeing us? We have to recognize that these are people under extreme pressures, so we have to use our time wisely. We have extreme workloads. And so we need to be proactive in our patient responsibilities, and that is before we get to the appointment, right? So they also have to been triaging their energy, because to be a clinician is all day long trying to, trying to get people to a better situation. Sometimes there might be several life-threatening situations in a day. Sometimes, so unfortunately, whenever we walk in the room, we're a comparator to whatever else that person has been having to deal with in the day. So we have to, so it, you know, physicians are not bright and shiny things that have all the answers, is basically what's important to understand. So it's really important that when we go in, we're clear, we're succinct, so we can be heard. And pain, fatigue symptoms, these are symptoms that require time and it requires thought. And we want to get the best out of our clinician, no matter who they saw before, no matter what difficulties they had prior to seeing us in the day. We want to help create an environment that's going to help them be their best thinkers and responders. And so we're going to look at some approaches to that. So, but expectations as patients, we should expect to have respectful communication. And why am I bringing these things up? Because these are issues that always surround, especially pain as a symptom. Non-dismissive thoughtfulness from your clinician, and direct communication between your clinicians. We can expect that. And reasonable solutions. And if our clinician, no matter how much we adore them and think that they're wonderful and have helped us so much for the past few years, if they can't come to a plan or a resolution, then we should feel it's our right to either request a referral to a specialist, or maybe get a second opinion. And any physician that's really worth their salt is only going to be glad for you to invest the energy to do that, because systemic sclerosis is a very complicated illness. And the more minds, the better. Yeah. So, and then clear expectations. So we should have, when we're leaving our visit, some firm plan that we feel like we can work with. Or we'll get a phone call later to discuss that element based on some other tests. But this is what we should be able to expect from our visits with our healthcare provider. So clear communication, being heard again. So identify the problem, state intensity of the interference, articulate, and be engaged. And so, first of all, identifying the problem. And again, all of these have the caveat of doing the work ahead of time. This is how we're going to get our best help. Identify each major concern and spend that time with each major concern. Even if they overlap, you can bring that into your thoughts, but make sure you've given space to each of those concerns. List them and rank them before we going to the clinician. What seems the most urgent maybe to you? What is the one that you're most afraid of? And spend time learning again how to describe each one. So the state of intensity of the interference. So what we want to remember, the clinician is always having a packed day, many things going on in their mind. So we have to help them. So keeping communication clear, avoid trying to convince of the symptom, because that's going to save time for really thinking about solutions. We have to trust that they're going to trust us to tell them what the symptoms are. Save that time. You can consider using a scale of 0 to 10, 0 being wonderful and 10 being impossible. So you can directly state either the level of distress about that experience, or the degree to which it interferes with your life. These are some succinct ways, or the degree to which, or all of these, or the degree to which it interferes with your ability to work and earn a living. These are succinct ways of getting your point across so that you have more time to talk about solutions and nuances that might not have come across your mind. But maybe you give an example or two of these things. Okay, so do this work ahead of time for each major concern. Okay, so articulate. So step back. I don't know why my slide isn't moving properly. So we step back and we see the symptom from outside of oneself. Take an inventory of what one sees from outside of ourselves also. And this will help to describe the physical symptoms clearly. Sorry about this. I don't know why it's doing this weird overlay. Yeah, so yeah. So the other thing is that sometimes doing that, creating space to think about what's wrong with us, is not something that we want to do because we don't want to admit there's something wrong with us, right? Sort of like, sorry guys for this, males out there, but it's like having this great big pocketbook filled with crap, right? And then you dump it on the table for someone else to please organize this, right? But it's our bag, it's our pocketbook. We have to organize it. It's so it's something like akin to that. And so, but to help ourselves, we have to take that time and that journey to that place that doesn't make us happy. But when we work through it, we'll find that, wow, I feel better. I feel a bit more empowered. I feel a little bit more connected to myself and less trodden all over by these negative symptoms. Can you see how that would work? How that could be liberating to take that time to describe and write down these one's feelings, one's experiences, descriptions related to one's symptoms, especially pain. Okay, so we're going to talk more about that. These slides are working. Okay, so here it's going to do it again. I know what's happening. This doesn't have the capability to do the animation, so it's leaving the blocks. It's okay. So be engaged. Being engaged says so much to a clinician. It means that we're not just expecting somebody else to figure everything out and struggle to get to an answer with less helpful information. So, so having notes, bring notes to aid your discussion, and take notes during the visit. Demonstrate a true partnership that, yes, I've thought about this and I've thought about you and how, I'm going to try to do my best to help you help me. Boy, that goes a long way. Know what medications one is taking and prepare to discuss the plan from the last visit, right? So, for example, maybe gabapentin was started. You may not have picked it up from the pharmacy, or you started it, but you didn't like the way it felt. All of this is okay, but be prepared to talk about what happened the last visit and explain any difficulties that occurred with that plan, because it expresses engagement and being part of that decision making. And this work happens ahead of time for each major concern, right? Okay. So cognition, anxiety, and depression. So these are real experiences for whatever reason. Inflammation is linked to depression. Fatigue is linked to depression. So there's a number of reasons why somebody living with a chronic illness, especially a multi-organ system disease like scleroderma, would experience depression. And depression interacts with pain. If we can help our depressed feelings, we can also help the way we can manage and perceive and experience pain. When we're depressed, pain thresholds lower, meaning that we're more apt to feel pain when we're feeling depression. And these are all a vicious cycle. When we're in pain, we can be fatigued, we can be depressed, that affects our cognitive, and this is all a vicious cycle between these. But one thing that I want to say clearly, and it's also something that you should expect, is that being depressed is not the answer if you're in pain. Oh, you're depressed. This is not an excuse. Both happen at the same, can happen at the same time, the same person. And it's, and many times patients complain that they're kind of being written off. So, but you should know that if you're having pain, if you're having any other symptom, it should not be written off that you're anxious or depressed. You're really feeling that symptom, and it's important to have that acknowledged. Okay, so okay, we talked about fatigue. I want to kind of move on. So pain and fatigues the body, taxes the mind and brain, taxes our emotions. It's important to know where the pain is coming from, again, in order to treat the pain appropriately and learn how to describe different pains so that we can help the physician locate it. You know, many physicians will feel helpless in the face of a patient that comes in and says, I'm just in pain all over. You know, and then the clinicians, and this is what happens. So you have to know this. Clinicians shut down. They shut down, and then there's a wall. So it's important to be able to be articulate about where the pain is coming from and what it feels like. So because it could be related to inflammation, it could be related to nerve compression, it could be related to muscle tension, and then again, another element of pain is that pacing, just as with fatigue, is an important management skill. So a word about fibromyalgia. Fibromyalgia, there's an issue with this word and this diagnosis because it's often misplaced. And it's often misplaced, again, as an excuse, just like depression, to say, well, it's fibromyalgia. There's so many reasons for pain in systemic sclerosis. And again, paying attention to the patterns, paying attention to the qualities of pain can help us help our clinicians get to the answer. There was a very good study done in Italy looking at a bunch of scleroderma patients that were diagnosed with fibromyalgia. It was something ridiculous, like not even a quarter of those patients had fibromyalgia. They had scleroderma. So it's very different. We're going to talk about the many reasons for pain in scleroderma. But basically fibromyalgia, because everyone's going to get a diagnosis of this. Yes? This is one of the greatest impediments for people getting treated and diagnosed and treated early with scleroderma, with lupus, you name it. This has been a catch-all, I'm too busy to think category that goes on for years until someone actually wakes up and sees the patient in front of them. This is exactly right. This is one of the greatest catastrophes in diagnosing scleroderma is this catch-all diagnosis of fibromyalgia. And yeah, and so one of the great things about the scleroderma community is the patients are out there from lots of different organizations. They're raising awareness. They've been helping getting patients into treatment earlier. Again, if you have Raynaud's, try to go to a scleroderma center and see if there's a chance that you could potentially have. This is what I know everyone here has scleroderma pretty much, or you're a carer of someone, a loved one of someone with scleroderma. But when we see these people come across the support group pages or on social media, we really want to advocate them. Like if they're having Raynaud's, if they're having these symptoms, make the effort to go to a scleroderma center, because they're gonna see things that other rheumatologists don't really see. Pitting of the fingertips, telangiectasias, slight changes around the mouth. Most 99.9% of rheumatologists really don't even do a nail fold capillary examination, right? And once you see that, it's like, with positive antibodies and Raynaud's, you're there. I think that's pretty much very close to the diagnosis, or this person's on the way to developing it. So, and I'm going to tell you this, people living with systemic sclerosis have been the major reason in the past couple of decades for diagnosing other people earlier. And they're directly related for saving other people's lives. So people living with scleroderma, caring about other people, supporting them, sharing information, getting them into a center where they can get a diagnosis early. It's all on the patient community. So you have that to be proud of, that you've made a big difference. Sorry? Yay! Yes, 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 yes. But you're going to hear this word fibromyalgia, and what is it? Anybody that's a medical student, a doctor, can have fibromyalgia. Somebody living with lupus or scleroderma, because fibromyalgia is something that's born of stress. It's born out of a sensation of stress and urgency. The muscles get ratcheted up and ratcheted up. They're trying to help us. Our muscles are trying to help us keep us together, but what's happening is they're ratcheting up to hold us together, and it gets to a point where they're impeding. And they don't mean to, they think they're helping. And then what happens with all this muscle tension, and then there's this neuroadaptability that gets messed up because of all the tension. So the things for fibromyalgia, very importantly, are sleep and exercise. And that's really the only, these pharma companies are going to want us to buy all these drugs and prescribe these drugs. They will help, but the only real things are, one, if you have an autoimmune disease, is treating that autoimmune disease, and then fibromyalgia wanes away because you're no longer having the stress of that illness and the pain that illness is causing. Exercise and sleep. That's it. That's how to cure fibromyalgia. If there's, and modulation. And so exercise brings us some self-regulation so that we can cope with stress. Exactly so. So I'm right, we have 15 minutes left. Am I right to say that? Thank you. Okay. So let's, okay, thank you. So how can we talk about our pain? So this is what we learned in medical school. So most scleroderma patients know more about scleroderma than any doctor that they're going to visit outside of a scleroderma center. You must know this. You must know that you are your advocate. You must know that you are your medical textbook. You know where to get the answers. You're connected. You've heard other people's stories. And so you must embrace that power. And learning more about, like with the articles that are available, incrementally learning a little bit more and a little bit more is going to make a difference. So here you are. We're all in medical school again. Old carts. This is a way to ask about people's symptoms, ask about pain in particular. So, but you can use this for each symptom that you're experiencing, whether it's fatigue, whether it's pain. So, when did it start? So, you will have already done this work ahead of time, right? So, you're gonna notice different types of pain, right? So, you might notice an intense pain in your wrist at night, but you might notice that when you're walking, you might have a heaviness in your chest. That's a different type of pain. You might notice when you're having a Raynaud's flare, what that feels like. So we have to isolate each different type of pain. So when did it start? The location, where does it hurt? And use your fingers. It hurts here. It hurts here. It hurts here when I do this. And you can only get that specific if we've stopped and explored our experience, our pain experience. Duration, how long does it last when it happens? It may go on and on and on. It may change in intensity. That's important information. Or it may only be when you're doing something in particular. What is the character, the quality? How does your pain feel? Aching, burning, shooting, tingling, throbbing, sharp, burning. Each of these pains that you have for different reasons are going to feel different. So a nerve compression pain because your wrist is inflamed, for example, and you're having shooting pains, that is going to be very different than this pain if you have diffuse disease, this throbbing pain under your skin, which is a different feeling. So for each pain, you want to be able to try to isolate a description for those qualities of that particular pain experience. Is there anything that makes it better? Alleviating, aggravating, anything that makes it better, anything that makes it worse. Those things are really helpful. Those things are really helpful to a clinician. So, for example, if I say when I turn my head, I have an aching over here. That's one thing. It could be muscle tension. But when I turn my head, I have an aching, but I also feel dizzy. That's a completely different story. That means, someone that's experiencing that might be having a nerve compression. So you really want to be able to talk about the things that surround it, things that make it better, things that make it worse, and associated symptoms. Does it radiate anywhere? Does it travel from my shoulder down through my thumb, for example? The timing and the pattern. Does it happen at a particular time of day, or does it change over the course of the day? And what other symptoms are associated? Does it, when it comes on, like I said, do you feel dizzy, or do you have palpitations at the same time, or something like that? Okay, so you'll have this in your handout, but this is really to give you an idea of how you can kind of talk about your body. You can point to different areas, just break it down, take your time. And because the more that we can be specific about where the pain is and how it maps in our body, helps us give information to the clinician. So pain quality tells a lot. Again, is it sharp, throbbing, achy, stiff? Stiff, think about stiffness as a pain. Electric, shooting, burning, tingling, numbness. So we were talking, all of these different qualities suggest different things. So sometimes suggesting inflammation, with or without nerve compression. Those are two different things. Infection has a different type of feeling. It has more of a throbbing, pressured feeling. Muscle tension has a different feeling. So pain is a myriad of, it's like got so many different, it's like a prism with so many different facets. And the more that we're able to describe it, the better we're able to get help. Okay, So, we talked about anything making it better. Sometimes, like telling somebody, like your clinician, running your hands under hot water makes them feel better. I can move them; it decreases the pain. Well, that kind of points to inflammation. And I feel better when I move around, or I have to move my arm above my head to get that pain to go away. Well, that's telling us there's possibly a nerve compression. So, can you see how how the patient is their information and their point of view is the most essential element to really getting help and something done. Does it hurt worse when I sit up or lay down, or it gets better with taking acetaminophen, or does it get better or with rest? What things make it worse? Lying down, bright light, etc., etc., etc. These are just ideas out of many that you could be experiencing. Any ideas what caused it? Very important. Any inciting factor? Well, I fell last week and the pain is still there. It hasn't gone away. I'm not sure if it's getting better or worse. Yes, I have been coughing, and so I have. That's why I have this. It's possibly why I have this rib pain. Or I noticed this after I had a hospitalization and I was, in there for 5 days, and then I came out with this shoulder pain. So this helps isolate. It helps clear the fog. Get more precise answers. And then is there anything that you've tried already? Medication or therapy? So the timing, time of day, time of night. Does it wake up in the middle of the night? Does it get better with rest or sleep? Does it ease as the day goes on? Worse at the end of the day? Worse in the morning if it's inflammation? After eating, after sitting for a long time. So old carts. Remember this when you're musing about your skin. There's a number of reasons why we can have pain in our skin, and sometimes we may not even realize it's in the skin. But there's skin tightening. There's this subcutaneous, meaning under the skin pressure in many patients with diffuse disease, and it's going to feel like a pressure. It's going to be a pain. There's going to be tenderness sometimes when folks touch us. It could be itchy, but that's a whole other symptom that we want to say, uh, we want to be able to talk about. So it itches. So, and sometimes we can have burning of the skin. So each of these things is important to communicate. And again, I have to say that it's the rare rheumatologist, because they're a scleroderma specialist usually, that's going to be able to recognize this. When you say you're itching, they're going to say, could that be scleroderma? This is probably rarely going to happen outside of a scleroderma center. Or I hurt all over, and then someone can see, they know to look to see that skin, it's not hard, but there's a tenseness underneath it, and it's so unless somebody's really seasoned in seeing many scleroderma patients, it's hard to make that. So you need to know, we need to know as people living with systemic sclerosis. And so and the skin, when it gets tight like this, and the underlying layers get tight, that can sometimes also cause an additional problem of what I've been talking about, compressing the nerves, which cause a second pain, a different pain, a pain because of the first pain, because of the mechanism of the first pain. So, but there's ways of managing this. First and foremost, if this is an issue, then we're looking at systemic treatment. Even if you don't have diffuse skin, this is the way to get this under control. And then in addition, there's massage therapy, occupational therapy, physical therapy for stretching, massage, manipulation, and this includes the hands. So we feel very strongly that I'm getting people into physical therapy and occupational therapy as soon as you can, and manage and working with your own body to do hand exercises, face exercises. We feel very strongly that this offsets progression. Janet, you have anything you want to say to that? Okay. And I also, want to say, like, with this pressure and tenseness of the skin, and there could be compression of the nerves. Sometimes trying to, like, when we're sleeping, especially, we might feel this because we're gonna find ourselves in a position by default where we're not paying attention. Use pillows to try to prop up and change the position of your arm. Pillows are wonderful in your bed for sleeping, your head, your shoulders, yes, but also changing the angle of your arm so that your limb is not dragging. That can cause thank you. That can create a better experience. Vascular Raynaud's, everybody knows what that feels like, and prevention is the most important thing you could be doing to alleviate that pain. Gloves, hand warmers, keeping core body warm. Keeping your core body warm is very important, and trying to avoid extremes of temperature. Um, and then there's other things that you could be doing: topical anesthetics, lidocaine, sympathectomy, and again, exercise increases circulation. Exercise induces vascular repair because this is a disease of vascular injury. You can't say enough about getting into early, learning about how to manage yourself by going and connecting with an occupational therapist and a physical therapist, because exercise is directly related to your vascular health and body warmth. Digital ulcers, it's the same thing. Topical anesthetics, prevention, protective dressing, being on the lookout to make sure that this is not getting infected. Remember, infection has a different type of pain. It's a throbbing, bursting, pushing against type of pain. Notice those different types of pains so that you can get the help you need in case you think you might have an infection. Calcinosis, it's the same thing. One of the things that patients have said that helps them is doing saltwater soaks to soften the skin around the calcinosis, and sometimes the calcinosis can relieve itself. So, but it's really important to let your physician know that this is what you're doing. Muscle, many reasons to have muscle discomfort in scleroderma. Muscle discomfort can be a result of muscle tension because you're coping with so much physically, psychologically, pain, etc. But 80% of patients, it seems, experience muscle involvement. And if your muscle involvement is related to inflammation, then the first line of treatment really is systemic treatment, i.e., mycophenolate, rituximab, etc., and exercise for repairing muscle, for recovering muscle. Joints and tendons. Okay, again, using pillows, cushions, and remember, if you have inflamed joints, really you have to seriously think about systemic treatment. And if it's not being offered to you, even if you have limited disease, you need to pose the question, because scleroderma is a condition that marches on and leaves damage. And the sooner that we can step in and quiet that inflammation, roll it back, the less likely we have damage. So that's the same with initiating systemic treatment and initiating exercise of all types. Okay, how do you help somebody understand you're having inflammation? Sometimes inflammation in your joints, to a new doctor, you need to make sure they understand, and they don't know oftentimes. Like, if these joints are involved and the wrist is involved, and in these joints, it's more likely that's an inflammatory distribution. Usually in rheumatoid arthritis, lupus, but also in scleroderma. But in scleroderma, the difference is that you can have pain everywhere. So that's a little bit of a conundrum. But again, finding the right doctor is important. Dry eyes. So this is another pain. Yes, it's another pain. It's not a body pain, but it's a pain that we live with. Gritty, sandiness that gets and interferes with our ability to communicate. Makes us feel just generally not easeful with ourselves. It's annoying. You want to keep your eyes moist before they get dry. Most people with scleroderma have dry eyes. So you want to keep them wet before they before they get dry, because once they get dry, it's hard to get moisture into those dry sockets on the cornea. So I really have found great help for my patients with this flaxseed oil that Refresh and Sustain do. It's an eye drop made with omega-3 flaxseed oil. It has a viscosity that stays on the eye to help keep it, and it's anti-inflammatory to some degree. And if conservative treatment isn't helping, you could go to ophthalmologist. They have great ways of managing, some great ways, punctal plugs, advancing treatment for dry eyes, because dry eyes really interfere and are uncomfortable. And move your eyes. Again, eyes have muscle all around them. So when we move our eyes, when we move, it helps these glands. And muscle has these chemicals that can help glands. And the same is true with dry mouth. Dry mouth is unpleasant. It's uncomfortable. It can be painful. The ulcers that come and create it can be painful. The cavities and the dental issues that come with dry mouth is really important to understand. Keep your mouth moist. Yes. Protect the teeth with fluoride rinse. So everybody that has dry mouth should be using a fluoride rinse in addition to their regular care. And why I'm saying that, what does that have to do with pain? Because this is prevention. If we can prevent pain in painful situations, that's where we want to be. Avoid using products, mouthwashes with alcohol that worsens dry mouth and creates ulcers. Reflux, read our article. We give you a whole bunch of stuff, but reflux and heartburn, esophageal spasms, extremely painful, is prevention. Staying ahead of the game, sleeping with the head of the bed elevated 60 degrees, wedge pillow, blocks underneath the legs of the bed, or jacking up the mattress by stuffing things under the mattress. And do not sleep on your right side because of the way the stomach's shaped. So everything in the stomach is going to roll out and press up against the esophagus. So this is another pain in systemic sclerosis, gastrointestinal. Cramping, bloating, nausea. Again, one of the greatest things that you could be doing is moving, stretching, which really helps. And prevention by really chewing food, not letting people hurry us. Life hurries us, so we rush when we eat, but that can create havoc in our gut and discomfort. And when our gut is uncomfortable, then we just don't feel right in the day. Small volumes, genitourinary, just bringing this up. Pelvic floor exercises for women and for men. Women with scleroderma sometimes complain of vaginal dryness, often complain of vaginal dryness, and pain with sex. And so some patients get improvement with systemic therapy, and that help, just like the skin can soften that area. But lubricants, know that they're out there, know that there's topical estrogen, and we think exercise can help to bring circulation to that area. So I was going to talk about, we have a half an hour break, right? So we're supposed to be stopping now, but I just wanted to just flip through these slides. Feel free to stay or go. But I just wanted to quickly brush over medications for managing pain, the first of which and foremost is physical fitness, physical activity and exercise, whether it's targeted for your hands, your face, and definitely for balance, and definitely for your whole body, walking, etc. These are really important. And if you come to my lecture or just read the book, read the article, you'll see why. So physical fitness increases muscle mass. Contraction floods the body with important biochemicals, decreases inflammation, increases circulation, reconditions nerves, relieves pain. It directly affects the thresholds and our ability to cope with pain. Joint lubrication, and many signals to the brain, and very importantly, improves sleep. Even humming and singing, you can consider an exercise. Humming, singing, and gentle micro movements. These are all beautiful things that can be done for ourselves. So I was going to talk about dysfunctional breathing patterns because that can exacerbate pain. Sleep is the next best important medication intervention for pain. Sleep. Quick. Um, and everybody being evaluated for sleep apnea with a screening questionnaire. And not only that, if somebody does happen to have sleep apnea after they do a screening questionnaire and then they get sent for a sleep study, using a CPAP is actually fantastic if you have reflux, and everyone with systemic sclerosis has reflux. So it's not the end of the world. It's the beginning of a whole new horizon if you happen to have a CPAP. Now, pharmacological treatments, first and foremost, is most people have active disease, even if their disease is moving along slowly. And that's an important point of one of our articles, is that people that have slow-moving disease get the short shrift because they often end up with terrific disability over time because nobody's paying attention or treating it. So the first and foremost is consideration of whether or not systemic treatment is needed, because that will roll back a lot of pain in somebody that has active disease, wherever this pain is coming from, whether it's nerve compression, whether it's joint involvement, whether it's the subcutaneous pressure that's all over your body underneath the skin, whether it's healing digital ulcers, whether it's I forgot what I was going to say, but yeah, but it, so you get my drift, or itching, and also dry eyes, non-steroidal anti-inflammatories. Chronic use, you must be aware, chronic use comes with a burden. Even if you're someone with no risk of cardiovascular disease, it comes with the risk of developing cardiovascular disease. Chronic use of NSAIDs. That's a chronic use of ibuprofen, Aleve, Celebrex. Some of these compounds were taken off the market because they were associated with extreme cardiovascular events. So, and then the other issue related to these is bleeding and GI bleeding. And as people living with systemic sclerosis, blood vessels are already fragile. And also the development of peptic ulcers. Okay. GABA modulators are probably my favorite. Gabapentin, not Lyrica. Lyrica seems to have too many side effects for me to come, but I prescribe mostly gabapentin and modulated. It also helps with sleep and it's very safe. SSRIs, very important, at least for a short time if you're feeling depressed, but it can also help modulate with pain. And it really is first-line treatment for anxiety, not anxiolytics like Valium or Xanax. Those are not real friends. Real friends are SSRIs in anxiety. Mirtazapine is another drug, helps with sleep, helps with pain, also helps with depression, and it can also help with appetite issues if you happen to be having some appetite. Did you get your picture? Okay, sorry. Tricyclic antidepressants. When I was a fellow, I used to prescribe these all the time to help people with pain. But the problem is they're very drying. They're very good for like nerve pain, and they're very good for sleeping, but they're very drying, which is not good for dry eyes, not good for dry mouth, and not good for a scleroderma gut that experiences constipation. Okay, so muscle relaxants, the same thing, drying. The anxiolytics we talked about, they disturb sleep. You think you're going to get a good night's sleep, but you don't have the opportunity, or the brain doesn't descend into that deep REM stage 4 sleep that's needed for restoration, that's needed to combat fatigue, that's needed for a proper working mind. Okay, opioids, they're not a friend in systemic sclerosis, especially because of the GI issues, potentially balance issues, and it fragments sleep. It creates a lot of problems with sleep and good restored sleep. And it again causes dryness to the mouth, eyes, and itching, which we don't need in scleroderma either. So thank you. So remember, again,